Welcome back, everybody. It's Dr. Z. Let's talk about postpartum depression and psychosis. Obviously, these days, the Lindsay Clancy case has been going around all over social media. It's obviously a horrifying and terrible tragedy what happened. And that's all I'll say about the case. These things have a process to go through, and that'll play out in court. But more so, I want to focus on the medical aspect of what these conditions are and what's considered normal and what's considered well beyond what we normally see. So we'll start off with postpartum depression, which is actually fairly common. In the US, the CDC data suggests roughly 1 in 8 women with a recent live birth will have symptoms of postpartum depression. In Canada, they found almost 1 in 4 mothers surveyed after giving birth reported feelings consistent with postpartum depression, so it is quite common and not unusual. And unfortunately, in both the US and Canada, these mental health issues related to pregnancy are becoming major concerns as far as causes of pregnancy related death and maternal mortality. Now, psychosis or postpartum psychosis, it's thankfully much rarer. It occurs every 1 to 2 births out of 1,000 births, but it's significantly more serious and it's considered a psychiatric emergency. So these things kind of go on a spectrum. First, you have baby blues, which are certainly much more common. After childbirth, hormone levels in the female body are going to change dramatically. Your sleep is going to be fragmented. Feeding might be difficult. You might not have an appetite, or you might still have nausea or vomiting. Not to mention the brand new human being that your entire world is now centered around. So, in simple baby blues, 40 to 80% will experience this after delivery, and it might include things like crying more easily, irritability, feeling overwhelmed, anxiety, emotional ups and downs, difficulty sleeping, feeling very unusually sensitive. And typically, this is going to happen within the first few days after the delivery, and it usually resolves on its own within a couple of weeks. So, the main takeaway is that baby blues are common and temporary, whereas postpartum depression is different and the next step on our spectrum. So, with postpartum depression, it's essentially a major depressive episode occurring in association with pregnancy and childbirth. And this can even be considered perinatal depression because a lot of these episodes will begin during the pregnancy rather than just after the baby is born. Now, in the DSM 5, it's called peripartum onset for episodes that begin in pregnancy or within 4 weeks of delivery. The actual risk stays highest throughout the first 6 months. And in reality, both in Canada and the US, it's considered postpartum mental health disorder if it's within the first year following childbirth. Now, some of the symptoms are going to be, again, persistent sadness or low mood, loss of interest or pleasure, significant anxiety, feeling overwhelmed, excessive guilt or feelings of inadequacy, difficulty concentrating or making decisions, changes in appetite, sleep disturbance beyond what's expected, feeling emotionally disconnected from the baby, difficulty functioning or caring for yourself, a sense of hopelessness or worthlessness. And this is why it gets tricky because a lot of these symptoms can pop up in those baby blues and just a natural part of having a newborn. And that's why it's looking at the entire picture and seeing how many of these symptoms people are having and for how long and how consistently. And a common myth is that in order to have postpartum depression, you have to hate your baby. And that's not the case. Some people can have a totally loving and normal relationship with the baby, or at least it seems like it. However, they're really struggling internally with all of these symptoms. And we alluded to this earlier, but there's a lot of things that happen in that postpartum period that can contribute to postpartum depression. There's not one single cause. After delivery, estrogen and progesterone levels are going to fall rapidly. And at the same time, again, you're dealing with sleep patterns and stress hormones, relationships, feeding demands, and all these things that are changing. So it's not just because of hormones. It's going to be an interaction between the biological factors as well as the psychological, social, and environmental factors that go with having a newborn at home. The risk is going to be higher in people with previous depression or anxiety during the pregnancy, previous postpartum depression, family history of mood disorders, particularly in first-degree relatives, people with limited social support or relationship problems, or intimate partner violence. These things are all going to contribute. Now, as far as treatment for postpartum depression, it's going to be usually a combination. So for mild to moderate depression, psychotherapy might be sufficient. And usually this is going to be cognitive behavioral therapy or interpersonal therapy. Exercise has been shown to help. So low to moderate intensity exercise, 150 minutes per week, had the greatest risk reduction. Bright light therapy can be a first-line treatment for postpartum depression specifically. And then there's the lifestyle factors, protecting your sleep, sharing nighttime responsibilities where possible, getting help from your family, maintaining your nutrition, trying to reduce isolation. Those are all going to support the treatment for postpartum depression. For moderate to severe depression, or when psychotherapy is not sufficient on its own, then SSRIs or antidepressants are commonly used. Usually sertraline and escitalopram are the first line for patients that have not taken medication for a mood disorder, and sertraline has the most data when people are breastfeeding, and it's considered safe. Now, a lot of people become worried about the risks of taking antidepressants and SSRIs and the potential effect on the baby, and these are certainly reasonable concerns to have and definitely something you should discuss with your doctor. But the part to keep in mind is that it's not just the risk of the medication versus no risk if you don't take the medication. There's also risk of leaving the illness untreated, which has its own consequences and problems and complications. So it has to be a balanced decision between the risks and benefits of treatment versus the risks of leaving the illness untreated. And that varies patient to patient. Many antidepressants do enter breast milk to some degree, but they're still considered safe to use for the ones we mentioned because the infant exposure through the breast milk is relatively low, and there's tons of extensive clinical data around this. However, it's all situational, and the comfort level of the parents and the family obviously matters, but maintaining maternal or the mother's psychiatric stability is obviously also very important. So sometimes people will switch to formula feeding, even if it's temporary, so they're able to start the medication that they need to be on. But ultimately, that's a discussion for you to have with your physician and make your own decision. Now, there is a new medication. It's called Zurzuvae by brand name, or zuranolone as the medical name. And rather than being an SSRI, like traditional antidepressants, it's a positive allosteric modulator of the GABA A receptor system. And it's related to this neuroactive steroid called allopregnanolone. And the unique thing about it, instead of being taken continuously for weeks and months like most antidepressants are, it's only given as a 14-day oral treatment. And in the trials that they've done so far, there was some improvement as early as day 3, with significant symptom reduction by day 15, and it was sustained throughout day 45. It was approved by the FDA back in 2023 in the US, and then Health Canada authorized it in December of 2025 for moderate to severe postpartum depression. Now, that doesn't mean it's for everybody. It's a relatively new drug, and like with any drug, it comes with its own host of side effects, including sedation, dizziness, other interactions. It's extremely expensive. It does not have a ton of data on it. So it doesn't mean it's the right drug for everybody, but it is something worth noting and discussing with your physician if it might be the right option for you. But that's pretty much the overview for postpartum depression. Like we said, these things exist on a spectrum. And in the next video, we'll go over postpartum psychosis, which is the far end of the spectrum and much more dangerous than what we've talked about so far. Hopefully that was helpful for you guys. Be sure to check out the newsletter and the community we're working on in the description. Everything is free. We have a free screening guide there to make sure you're caught up on all your screenings for all kinds of cancers and other diseases that your primary care physician should be screening you for. So be sure to check that out. Check us out on any podcast platform so you can listen to us on the go, and let us know what you want to hear about next. We'll see you next time. Cheers.